Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Hello everyone, welcome back. Today we're going to talk about a paper looking at one-year outcome after conservative management of appendicitis. This is a longer-term follow-up of the COVID-harem study, which we discussed before in this journal. Prof. Saba will then be talking about challenges and frustrations with RCTs. I'll leave you to it.
So, hello everyone, I'm Shadman and I have Gio with me. We are going to discuss about a journal. It's Predictors of Appendicectomy 1 year after the antibiotic treatment for acute appendicitis, published on 21st August this year, and the study was done by the COVID-harem group. I have the PubMed ID on the link. So, Gio, would you like to run us through the background of the study?
Sure, of course. Well, we have discussed a number of papers on conservative treatment of appendicitis in this forum, from the CODA paper to the APAC trial, including the long-term results, to the COVID-harem, the original COVID-harem publication itself. And there's been a lot of discussion about the success rate of conservative management, the potential issues with selection of patients, particularly for RCTs that pick particular subsets of patients with CT-proven appendicitis in absence of fecalith, for example. And certainly there remains a significant degree of reluctance in a lot of surgeons to both talk about it to patients and to adopt it in their routine practice, with exception, obviously, but I still feel it and see it on a regular basis in a lot of the places I've worked in the past few years. One of the big concerns about conservative management of appendicitis is the risk of missing a malignancy in the appendix. This has been a concern also due to some medical legal cases that have emerged not long after COVID. And certainly recurrence rate seems to be kind of the element that really swings the balance towards performing an appendicectomy rather than offering conservative management, and also for patients to accept conservative management, at least in my experience. So this paper tries to shed some light on some of these questions and problems that people have encountered in the past few years trying to do this. So ball back to you for a little bit of PICO.
Yes, thank you. So in the PICO format, the patients here are the ones that are suffering from acute appendicitis based on both clinical or radiological diagnosis. Before we only went through with the clinical diagnosis, but now we have some radiological aspects as well. We can do CT scans to chart out the appendicitis. And then the intervention is the patients that are getting treated with the antibiotics, and we're comparing it with the definitive surgical procedure appendicectomy. And the outcome for this paper is the 1 year appendicectomy rate in the group that was managed conservatively, and predicting the failure of the conservative management in that group, and the malignancy rates that was found during the studying of this paper. Gio will walk us through with the methods and the predictors of the study, please.
Yeah, the study design is, as we described before, for COVID-harem, so a multicentre prospective observational cohort study. Originally, 97 hospitals participated, so quite a big number of patients were included. Only 49, so roughly half, provided 1 year data for the patient they input in the database originally. Recruitment was for a relatively long time, March to June 2020, and here we're talking about 1 year follow-up. A number of variables were handpicked by the authors in this context to try and determine whether they are associated with the risk of having an appendicectomy or not after conservative treatment, whether for failure of treatment or simply by choice. Some of them are reasonable, like age, gender, CRP, white count. Some of them perhaps less intuitive. Certainly, there is one that is worth mentioning, the AAS, which is a composite scoring system used to determine whether a patient is likely or less likely to have acute appendicitis. This composite score does include already CRP and white count, as well as a number of clinical indicators and history-related indicators. So there is a degree of collinearity to an extent in the variables that were chosen here. And some of them are quite reasonable and well known to be associated with the risk of having your appendix out. Some of them not so much. Obviously, I'll leave to you to judge if this list is comprehensive or appropriate to an extent. Ball back to you for some more.
Yes, thank you, Gio. So here we can see the results of the study. If you look on the fourth point, the overall appendicectomy rate for that year was only 29%. So 71% patient was managed conservatively. And among that 180 patients, 67 had the unsuccessful antibiotics management at their first presentation. So they had to go for the emergency appendicectomy on that setting. And then 82 other patients came back at certain point with the same type of pain, diagnosed recurrent appendicitis, and had to go for surgery. 31 of those patients, other patients, had elective appendicectomy. They didn't want to they opted out from the conservative management. And the most common reason for this elective appendicectomy was a planned interval procedure that was later happened down the line on that 1 year time period. There's another result graph system that Gio will explain kindly.
Yeah, so this is a time to appendicectomy for patient who had an emergency appendicectomy after initial non-operative management. So a mixture of failure to respond and a mixture of having an emergency operation at some point in the time after, either for recurrence of symptoms or simply because they were just put on an emergency list. What the authors are trying to say is that the vast majority of appendicectomies actually happen within the first half of the year after the initial conservative management attempt. That is to say, if you manage to pass 6 months without having had your appendix out, you're probably going to be fine. Certainly, this seems relatively logical, but other studies have shown that this appendicectomy rate and persistent symptoms and recurrences actually keep going and going up to 8 to 10 years down the line, as demonstrated in the APAC study. So I'm not entirely sure we can draw solid conclusions from this, especially in a non-randomized setting, if you like. Ball back to you.
Okay, thank you. Here we have the histology that was available for the patient, most of the patient that had the appendicectomy done. 16% of the histology of those patients were normal in total. That's 26 out of 167. And then those patients that had them removed emergency, 6% of the histology was normal. So they did not have appendicitis on the histological evidence. 58% was normal or had some signs of previous appendicitis when they removed it at an elective procedure. And those that had the routine interval procedures down the line, 73% of the histology was normal. So probably they did not have appendicitis on the presentation. So you can see from this chart that there's relatively low percentage of histology that actually came back positive for appendicitis if you have done it at a routine interval procedures at a later settings. There is also some other issues with the malignancy, and I think Gio will talk us through about that.
Yeah, so the authors looked particularly at the number of malignancies that were diagnosed on procedures that were delayed, so procedures that were performed either on an elective basis after an initial presentation with acute appendicitis, or that were performed because of persistent symptoms sometime down the line. They diagnosed 10, so an overall malignancy rate of 1.6%. 7 were carcinomas of the appendix and 3 were NETs. 5 were picked up on specimens done on emergency appendicectomies, 3 following concerning follow-up CT findings, and 2 just on routine interval appendicectomies. 2 of them required an additional resection, so a hemicolectomy. 1 of them actually needed systemic chemotherapy. The authors go a little bit on the bold side here, I feel, and state that 1 year post-presentation, you would expect patients with significant cancers to present. I guess I could take that point, but what do you mean by significant? And, you know, significant to who? We're talking also about especially NETs, malignancies that happen in relatively young people that tend to be very slow growing, but that if left untouched for a rather long time, can cause quite significant problems, and as demonstrated by the authors' data set themselves, sometimes require right hemicolectomies, sometimes require systemic chemotherapy. So you'd argue that in this set of delayed procedures, they've already picked up 2 significant cancers that you don't know, but potentially could have been treated with a simpler procedure on the index presentation. No one knows. It's impossible to make a solid assumption here, but it is possible. So I think it's worth keeping that in mind. Bo, back to you for some more.
So let's talk about some limitations of this journal. There's some self-reported one that they have already said that the decision to go for which management is it actually depends on the surgeons that's treating the patient on the index presentation. And because we don't have a predefined criteria, so to where to offer the conservative and where to offer the surgical management. So that's the kind of limitations. Also, because it occurred during the post-COVID period, so there was reduced participation from the hospitals, and a lot of patients got lost during the follow-ups. They were not followed. So we don't know if they came back again with appendicitis or any other pathology after their index presentation. And then when we went into the open phase, when the COVID restrictions were lifting up, and then we started to go back to the non-operative treatment, because it's mostly influenced by the individual beliefs of the clinician that was doing it, but they quickly resumed to the operative management rather than discussing it with the patient about both the conservative and the operative one. Some other limitations, Gio?
Yeah, so I kind of picked on a few more points. I've read the paper a couple of times. I couldn't quite work out what diagnostic modality was used and the index admission for the patients that then had their either appendicectomy acutely or appendicectomy as an interval procedure, which to an extent makes you think, well, you know, you've got a high rate of negative appendicectomy specimens, but did you actually have appendicitis in the first place? I'm not entirely sure. And if you did have imaging proven appendicitis, then based on other trials out there, then it's reasonable to offer an appendicectomy to prevent recurrence. And we're talking about studies that have a much longer follow-up, up to 10 years. In a lot of instances, follow-up is subjected to patients' complaints. So if a patient attended with right left fossa pain, were clinically diagnosed with acute appendicitis, actually never had appendicitis, but then carry on having right left fossa pain because, well, we're giving them antibiotics, but actually that's not what they needed because they didn't have appendicitis. Then we take their appendix out and then we kind of complain that they have a normal appendix on histology. Well, that's quite logical. It's because we've treated a complaint without actually having a diagnosis. I can't work out if that is a phenomenon that effectively is happening in this cohort of patients, just reading the paper. As I was talking through the variables that they looked at to determine as potential predictors for having your appendix removed, I mentioned that few of those variables are quite collinear with each other, particularly the AAS and CPY count. They also run a lot of statistical tests, and you would think that perhaps some corrections for multiple statistical testing would have been appropriate. And I didn't see that in the methods. I can't work out what they mean by significant malignancy. And well, as you see in the conclusion, the authors specify that CT is the best follow-up modality for patients over the age of 40 after having had conservative treatment of acute appendicitis. And they advocate for follow-up based on the increased risk of having a malignancy in the right side of the colon when you present with acute appendicitis over the age of 40. And some of that is endoluminal cecal or ascending colon adenocarcinomas, and some of them are malignancies of the appendix. A CT scan's reasonably good, I would say, at picking up malignancy of the appendix, but certainly a colonoscopy would be more appropriate at investigating the right side of the colon. So I would take that recommendation with a pinch of salt, although they base it on their data. I would take it with a pinch of salt. Right, I'll leave you the floor for some conclusions.
So, in conclusion, our collaborative suggests that the patients that are diagnosed with uncomplicated acute appendicitis, they should be counseled regarding the option for non-operative management alongside with the operative one, but they should be counseled obviously for the non-operative management with antibiotics. But when we are considering a patient to go for a non-operative management, we should have an AAS score in our hand, score that, and then we also need a cross-sectional imaging to rule out the diagnosis or specify it, possibly CT scan. If those patients come up with a very high AAS score, or in the scan we find that there's a fecal leak, then non-operative management is not recommended. Then we will push him or her for the surgical management. And in patients who are 40 years or older, an initial and interval CT down the line should be considered to find up any pathologies that are building up on the right side of the colon. And here we have some perspectives for the journal, which you guys can take a look. I think that's it. We can wrap up. Thank you very much.
Thank you.
As usual, after the presentation, we talked about a few issues concerning the paper. We reiterated some of the limitations we discussed already, and we focused our attention particularly on malignancy rates and the possibility of there remaining some missed malignancies in the non-operated cohort. We had a brief look at the outcome of other studies, particularly RCTs, such as CODA, and reports suggest that in the conservatively managed cohorts, malignancy rates are relatively comparable to the data provided by the authors. We then focused on the definition of significant malignancy and potential delays in diagnosis associated with this. And finally, we touched upon the importance that this data has on counseling of patients that are treated conservatively for acute appendicitis. We discussed how much the authors of this paper have a strong feel that we should manage appendicitis conservatively more often, and how it is important, particularly for data that is presented on a portion of the population that was originally included in the study and in a non-RCT setting, to be taken with a pinch of salt, and how there are still quite a few unanswered questions in the context of conservative management of acute appendicitis. I will now leave you to the teaching session. Enjoy.
We've had a few talks on randomized controlled trials, and we have previously highlighted the challenges that surgical RCTs face in not just designing the RCT, conducting the RCT, but also interpreting the results and making it generalizable, making the results of the RCTs that you do externally valid to a much wider group of surgeons out there in the community whose practices might vary, whose local facilities might vary, and whose patients' complexities might vary as well. So surgical RCTs are a particular problem, very dissimilar to medical RCTs, as you would imagine. And I was going to illustrate the difficulties in surgical RCTs using an example in my practice. There is a condition called post-surgical hypoparathyroidism, a lot of you may have heard of, where the thyroid surgeon, while doing a total thyroidectomy, can inadvertently damage the parathyroid glands, damage their blood supply, inadvertently remove them, and the patient has this condition called post-surgical hypoparathyroidism. And there's been a lot of research ongoing, particularly in the last 20 years, on how to reduce the risk of this problem. There are lots of short-term issues, lots of long-term morbidity. In fact, there's also an impact on mortality. If you are hypoparathyroid after thyroid surgery, in the long term, your mortality is slightly higher compared to a population who did not get hypoparathyroidism. So one of the proposed solutions has been to incorporate fluorescent imaging of the parathyroid glands during the operation. And fluorescent imaging is considered to help by reducing the likelihood of the parathyroid glands being inadvertently damaged or removed. And also, fluorescent imaging helps in identifying the blood supply to the parathyroid glands. And by identifying the blood supply, you're able to preserve the viability of the parathyroid glands. So on the top, you see how a small snippet showing how fluorescent imaging helps you see the parathyroid glands. And in the bottom is a little video of how you can assess perfusion by injecting ICG indocyanine green during surgery, and you can see the perfusion of these parathyroid glands. So I've been involved for some years in this multi-centered randomized controlled trial, and that we have carried out in the UK, and this has recently been concluded, and this is called the NIFTY trial, Near Infrared Fluorescent Imaging to Prevent Post-Surgical Hypoparathyroidism. And because surgeons do thyroid surgery very differently, we initially thought we should do what we call a process evaluation, where thyroidectomies were observed by qualitative researchers who also did surgeon interviews, and we did some surveys to establish the variability in practice in the UK and to get a consensus on what steps of the thyroid operation should be mandatory and what steps should be optional. We put it to an expert panel, and then we developed a manual for the trial to stipulate which steps of thyroidectomy should be documented and which should be mandated and which should be optional in both the standard and the experimental arms of the trial. Then we set out to do a seamless phase 2, phase 3 design, whereby we randomized patients initially into the phase 2 arm of the trial. When I say randomized, we had one group of patients who underwent the standard operation, and the other group underwent in the experimental arm, underwent the operation under the guidance of fluorescent imaging. And we looked at some outcomes. Our key outcome was 6-month hypoparathyroidism rate. This trial went through phase 2 and then had to be concluded. We didn't go through to phase 3 because we found that there was no difference between the two arms, and therefore the new intervention was considered futile. Now, when we assess, or when we have to assess interventions like these, surgical interventions particularly, these are complex interventions, as you can imagine. It'd be easier for you to understand why I say they're complex if you've assisted or done thyroid surgery, but I'll try and explain as we go along. Now, what are complex interventions? The complex interventions are interventions that have any one of the different sort of characteristics that you can see on the screen. They can have a number of interacting components. They can have a number of different sort of behaviors, which means that which refer to the different ways in which the operation is done in the standard or the interventional arm. There could be a number of groups at which the intervention is targeted. There could be a number of different outcomes and differences in how the outcomes are defined. There could be flexibility in how the intervention is actually implemented. So if you have any one of these issues with your intervention, that becomes a complex intervention. There are other ways in which complex interventions have been defined, essentially non-standard interventions, having different forms in different contexts, have multiple interactive components, and non-linear causal pathways. Again, I'll try and explain this as I go along. Now, surgeons would typically ask, well, why don't we just keep things simple? And you can make this argument for any intervention in surgery. And you could keep it simple by saying, well, I'll ask a very simple question, such as, can fluorescent imaging be effective in reducing long-term hyperparathyroidism in thyroid surgery? And design a simple enough trial to just get to the bottom of this question. However, the answer that you get to the question, to the simple question you've asked, may not be very useful to a wider community of thyroid surgeons if the surgeons have different perspectives on a number of different things. Surgeons could have different perspectives on what actually fluorescent imaging means. Is it an image-based system? Is it a probe-based system? Is it autofluorescence? Is it ICG fluorescence or some other dye? How you implement fluorescent imaging? Do you do it right at the start of the operation, throughout the operation, at the end of the operation? How do you interact with the fluorescent imaging and what it shows you? What is the interaction between how you change your operation in response to what the imaging shows you? And what about the outcomes? Is long-term hyperparathyroidism the only outcome? Is short-term hyperparathyroidism important? Would you be interested in other outcomes such as operating time? Does it help you conclude the operation quicker? Does it help you train residents quicker? So it's very difficult to keep things simple in a complex intervention. The next question surgeons would often ask is, do we really need randomized controlled trials to evaluate these things? Can we not go with our gut feeling, with plausibility, with our experience and tradition? Now, the answer to that is we do need to assess surgical interventions as we would need to assess any medicine or any drug. And that's the basis of evidence-based practice. And we do need to be able to answer questions such as, are they effective? What are the risks? What are the costs? And do the benefits outweigh the risks involved? And we need to be clear on whether this new intervention or technology is better compared to the standard. And just saying better isn't necessarily complete. You need to be clear on better for who. Is it better for the surgeon in some way, better for training, better for patients, better in what way and to what extent? Now, in some surgical procedures, the benefit to risk ratio is pretty obvious, and the intervention has clear plausibility or a biological rationale. For example, you're not going to be asking for evidence to jump off an aeroplane with a parachute. You'll just use the parachute. Similarly, in surgery, you've got some interventions such as running a bleeding duodenal ulcer, fixing a fracture, doing a laparotomy for peritonitis. The benefit to risk ratio is so obvious that you're not going to be saying, oh, I need a randomized controlled trial to assess this intervention. But many other surgical interventions have a very marginal benefit, sometimes no benefit, but have still been introduced into routine practice. I've highlighted some examples. I've listed some examples. You may have a problem with one or more of these, but that's up for debate. Like, for example, RFA of liver metastasis, debulking surgery in advanced renal cancer, keyhole operation on the thyroid gland. But these interventions have been introduced into practice by trial and error, often reported by centers of excellence, where some experts have done it, have had good results, and then they get disseminated. Sometimes pushed by the industry, sometimes wanted by the patient, sometimes pushed by enthusiastic surgeons. Some good examples. They could be success stories like laparoscopic cholecystectomy. You're probably aware that we started doing laparoscopic cholecystectomy and gradually replaced open cholecystectomy before there was clear evidence on the basis of randomized controlled trial. So this is purely an introduction into practice by trial and error. Some examples, which are not so successful, that I've listed on this slide, are gastrojejunostomy without vagotomy. That was a disaster. Jejunal bypass for obesity became very popular for a few years and then died out. So clearly, in some instances, you really don't need randomized controlled trials, but there are many, many, many other instances where you need them. So if you're coming back to our example of fluorescent imaging in thyroid surgery, and you're asking the question whether fluorescent imaging is better than standard surgery in reducing parathyroid damage and reducing long-term hypoparathyroidism, a number of people have said that, well, it clearly works because the parathyroid glands fluoresce at particular wavelengths. You can visualize this fluorescence at surgery, and if you see the parathyroid glands better, then you're not going to damage them or remove them inadvertently. And finally, people say, well, if you can demonstrate perfusion of these glands by injecting ICG and looking at the blood vessels going to the parathyroid gland, you're able to assess viability. So because it is so obvious and logical that using fluorescent imaging can potentially reduce parathyroid damage, why do you need randomized controlled trials? What is the problem? Why not you just get on and use the technique? For every problem, if there's an easy solution, it is very often that the solution is neat, plausible, but wrong. So you might have a solution that appears very logical and intuitive, but you will see in medicine and healthcare that these so-called plausible solutions often don't work in the real world, are not effective. There are many examples, and many people would make the point that without rigorous evaluation, a number of surgical technologies and interventions just turn out to be toys for the surgeons to play with, or gimmicks. You can see on the screen, I've got a picture of the Angelchik's prosthesis. Some of you may have heard of it, used to allegedly reduce the risk of reflux disease and for hiatal hernias, no longer used because of terrible complications that follow. You may or may not have heard of the bypass between the external carotid and internal carotid circulations that was touted as a way of preventing or treating stroke. So there are lots and lots of examples of surgical technology that have fallen by the wayside. And there's a guy called Scott, who's a gynecologist, who very eloquently described these kinds of technologies as the Scott's parabola, where he says it all starts off with a promising idea. There are some initial case reports, and people get very excited, particularly surgeons. And then surgical pressure, media pressure, patient pressure, these technologies get introduced into standard practice. And after a while, doubts start to creep in. You get some major complications, and these devices and technologies fall into disrepute. However, there are some other technologies that have not been through randomized controlled trials, but have still withstood the test of time. And in my sphere of practice, nerve monitoring, intraoperative nerve monitoring of the recurrent nerves is one good example, where after an initial peak of inflated expectations, as you would call it, people get a bit disillusioned, a bit deflated, and then after a while they start to realize that, well, it's not the panacea, it won't completely avoid nerve injury, but it's got a role in thyroid surgery. So I hope I've emphasized and explained that we do need to evaluate complex interventions. There are a number of factors that drive innovation in surgery, and one of the most important underlying factors is a surgeon's desire to innovate and improve patient outcomes. Of course, there are other factors, some of which are industry-driven, some are patient-driven, and some are simply the need to increase efficiency and reduce costs of your treatment pathways. But the innovation has to be assessed for reasons that I've just explained, and that assessment should really be on par with medical innovation, because this is what forms the basis of the so-called evidence-based surgical practice. But the problem with the surgical innovation and the assessment of the innovation is that it's not as straightforward as medical practice. Well, assuming if you believe that the assessment of drugs is straightforward. But the particular challenges of assessing surgical technology has led a number of experts to come together and propose what they refer to as the ideal framework. Now, I think we've got a set of slides on the ideal framework, so I won't dwell on it, except to just highlight that there are these phases in the ideal framework that a particular technology needs to go through, starting off with the idea stage, and then the development stage, the exploration stage, followed by the assessment stage and the long-term monitoring stage. And if you just pick out phase 3, which is the assessment phase of the ideal framework, this is when a technology is gaining widespread acceptance and is being considered by many people to be a replacement for current treatment. And this is where you start to think about doing randomized controlled trials of the technology in comparison with the standard treatment. And randomized controlled trials, as you all know, sit right near the top of the evidence-based hierarchy that underpins our practice of evidence-based medicine. Now, coming back to fluorescent imaging. Like I said, there are some specific difficulties in assessing surgical interventions. And the first is that in a complex intervention, and I've explained what complex interventions are, where there are more than one component, and there's some flexibility in how you actually implement the intervention, and that there are interactions between the components of the intervention and the way you do your operation. Also, in surgery, there are lots of confounding variables. There could be differences in how experienced the surgeon is, what the surgical volume is, what the influence of other members of the team, like the anaesthetists and the nurses are, and how the patient is cared for both preoperatively and postoperatively. There's also the learning curve and the impact of the learning curve on the outcomes. Your learning curve could be with your standard thyroid surgery, and you also have a learning curve in how you use the technology. The other big problem with many surgical technologies are that the technology itself improves. So by the time you start a randomized controlled trial, especially a multi-centered one, by the time you get funding, design and run the trial and wait for medium to long-term outcomes, it'll be several years down the line. And the technology would have changed dramatically and may not be similar to the technology that you've actually spent years evaluating. Which then leads to the question as to when do you actually assess the technology? How long do you wait for the technology to ripen, to mature before you actually assess it? And that leads us to the so-called Buxton's law, which says that it's always too early to assess a technology until it is suddenly too late. When we say too late, we mean that the technology may have just got completely embedded into practice and you're not going to change that, or that the technology has been used and discarded, by which time it's too late to then assess it in an RCT. So there are some specific properties of complex interventions, and I'm going to go through these properties. They might be a little bit complicated and difficult to understand if you're hearing about this for the first time, but I think it'll provide you some useful insight into these problems, especially if you're going to be involved in doing randomized controlled trials or you're going to be reading papers on randomized controlled trials. I hope this will be useful. The first thing is that often there are multiple components to the intervention, to the complex intervention. Like I've already explained, the different ways in which fluorescent imaging can be construed. There's this autofluorescence, ICG fluorescence, differences in times of use, differences in how you interpret it, and how you make decisions based on what the fluorescent imaging actually shows you. There's another property with complex interventions called non-linearity, which essentially refers to, with this example in mind, you can, it's not an all or none thing, the fluorescence. And if you have some fluorescence or a lot of fluorescence, they can be dealt with in the same way. And the decisions on what to do with a gland that is not fluorescent at all, which you might consider non-viable, it really depends on what the other glands are like. So it doesn't flow in a very straightforward manner as to what anyone would do if faced with a non-viable gland. There's another property called emergence, which refers to unanticipated events arising without intention. For example, you might detect fluorescence in a lesion in the central neck away from the parathyroid, and that could turn out to be a lymph node metastasis from thyroid cancer. And if you pick that up because you use fluorescent imaging, that'll completely change the extent of the operation that you're planning to do. There's another property called feedback. Basically, that's an observation that reinforces, balances, or diminishes another factor. So, for example, if you're using fluorescent imaging and you identify a really small inaccessible gland on one side of the neck, it might prompt you to change your technique on the other side so you can identify the gland on the other side in a much better or an earlier manner. There's something called adaptation, which refers to a change in behavior in response to an intervention. So if you're concerned about parathyroid viability using fluorescent imaging, then you might change the extent of surgery. And there's another property called path dependence, which refers to specific paths or strategies you might take because of some specific complex local reasons. For example, if you have a non-viable parathyroid or a parathyroid that might be a bit ischemic, in some centers, you might, before you reimplant it, you might want to do frozen section to make sure it's not cancer tissue. In some other centers, you might not do it because you don't have facilities for frozen section. And finally, actually, most importantly, there's human agency as a property of a complex intervention, which essentially refers to your values, your beliefs, skills, and goals as a surgeon, and how much trust you place on the technology, and how much you would use the technology to make your decisions, or how much you would just rely on your own instinct and what you see with your naked eye. So problems, these kinds of problems are not unique to surgery. So if you look at complex public health interventions, they've got very similar problems. And they call these trials realist randomized controlled trials, where they say that complex intervention RCTs take account of the complex nature of the intervention to understand what works, for whom it works, and under what circumstances. However, there are other people that say realist RCTs never work, and the phrase realist RCT is an oxymoron. So there's this debate going on in the literature as to how complex interventions should be assessed in using the scientific methods or the study designs we currently have. So coming back to the research question, I said, initially that the question for us was whether fluorescent imaging is better than standard thyroid surgery in reducing hypoparathyroidism. The important thing to keep in mind is that, and this is really important for complex interventions, is that the question underlying your study of the complex intervention should be specific, focused, and clear. And you've got to keep in mind that there might be other research questions that might be equally valid. There might be another researcher who says, well, actually, I'll use fluorescent imaging, but my question is, does it help thyroid surgical training? Or somebody else might ask, does fluorescent imaging actually help me remove more lymph nodes in thyroid cancer surgery? Or they might say, I'm not really interested in long-term rates, I'm interested in short-term rates, and so on. And again, the technology in question might have different versions, might have different types. I've already mentioned that there are different types of fluorescent imaging, autofluorescent imaging, and fluorescent imaging using specific dyes. And there are these image-based systems and probe-based systems, which probably will be a little bit complicated if you've not heard of this before. So going back to looking at fluorescent imaging in thyroid surgery through the scope of the ideal framework, the first question is, is the treatment described a complex intervention? Yes, it is. The second is, have you got preclinical studies being performed to assess harm? Yes, in the context of fluorescent imaging. Then the question would be, have early human studies and technology modifications been done? The answer is yes. And have they been replicated and quality measures have been defined? The answer is yes. And finally, have you done randomized controlled trials? So having been through all of this processes in the ideal framework, you then do a randomized controlled trial, which is what we've done. And what do you then do if the randomized controlled trial results are equivocal? In other words, there's no difference in long-term hypoparathyroidism rates. What does it actually mean? Does it mean that the technology is useless? You might as well get on and do your standard operation and forget about the fluorescent imaging. Could it be that your surgery has got better, you're now operating differently, or the technology has changed, and before you condemn the technology, you have to think as to whether maybe you trialed an old version of this, maybe the newer versions might give you a different result in another trial? Or do you ask whether you've asked the right question? You need to ask a very clear, focused, and defined question if you're planning an RCT. And if you've said, oh, my question is whether this improves long-term hyperparathyroidism rates, what about the other questions whether that you could ask and get a different answer with regards to the technology? And then if you think that the fluorescent imaging really works in your hands, but then the RCT has given you negative results, then you're also wondering whether randomized controlled trials are the right tool in assessing surgical technology. Or maybe there are some design issues in your RCTs. And the design issues could be simple things like maybe the surgeons haven't got used to the technology and they're not using it right. Maybe the technology is used in so many different ways by the different surgeons in the trial, so you've not really standardized it properly. And then finally, maybe there's a Hawthorne effect, which simply refers to the fact that surgeons know they are in the trial. So regardless of whether you're in the standard arm or the technology arm, they're taking great care and are going to great lengths to reduce the risk of this complication. Now, this particular trial, the NIFTY trial, like I said before, has closed after phase 2 because of negative results, because of futility. So what are the implications of this? The first thing is maybe that there was a type 1 error in the trial. Maybe there is a real impact of the technology, but the trial hasn't picked up on it. And what can then happen is you lose the opportunity to assess other outcomes that can be influenced by the technology. Maybe the technology is good for training, reduces operating time, reduces short-term outcomes, short-term morbidity, but you haven't picked that up because the trial was designed to look at a specific long-term outcome. Having a negative result in such a big trial can dampen further research. People might say, fine, that's it. Fluorescent imaging is of no use in thyroid surgery, regardless of the type of fluorescent imaging, regardless of how sophisticated your technology has now become. And then you might also make draw the conclusion that if it doesn't help in routine thyroid surgery, it may not help in complex thyroid surgery. It may not help in settings where thyroid surgical volume is not that high. You've done a trial in high volume centers. Maybe the technology is not needed by the experts. Maybe the technology is needed in people who don't do much thyroid surgery, who do the occasional operation. And then sometimes, as we're finding with fluorescent imaging, I think that it is particularly useful in difficult operations. But if a trial of this nature has shown that it is not useful in the standard operation, then you're not going to get funding to use it in the complex or high-risk operations. So finally, I think I've got just one or two more slides. My personal experience, what's happened with my hypoparathyroidism rates. So over 12 years, I found that my hypoparathyroidism rates were fairly stable, exactly at 5%. Neither my experience nor my volume helped me reduce my rates. And in the last 2 years, my rates have dropped from around 5% to virtually 0.5%. And this in the last 2 years, I've been getting involved in the trial. We've been recruiting patients into the trial. Now, you could say, I've been using the technology, that's why my rates have gone down. However, when I looked at my data, the rates were the same regardless of whether I use the technology or not. You could say I'm getting involved in the trial, so there's this protocol effect. of the randomized control trial, or the Hawthorne effect, the effect that I'm being observed. But the rates were the same regardless of whether the patients took part in the trial or didn't take part in the trial. So even if they took part in the trial, my rates were the same regardless of whether they had fluorescent imaging or no fluorescent imaging. So what's happening? I don't know what the answer is, but I have changed behavior. I've changed how I do a thyroidectomy now since I started using the fluorescent imaging. I've gained a lot more knowledge on how the blood vessels to the parathyroid glands are related to the thyroid capsule. I've also been, because I've been getting involved in the trial, been taking very detailed notes of the locations of the parathyroid glands, the blood supply, and how I do the operation, and willingly or unwillingly been involved more in reflective practice. So it could be that these have changed my results. But that's only happened because we started getting interested in the technology and getting enrolled or enrolling our patients in the trial. So, in summary, I was hoping to illustrate the challenges of assessing surgical technology with randomized controlled trials. And I wanted to emphasize that many surgical trials assess interventions which are complex. And I hope I've explained to you what a complex intervention is with an example. Also, I hope that you understand why complex interventions are difficult to evaluate for effectiveness, why surgical trials struggle to establish effectiveness. So it's not because surgeons don't know how to do randomized control trials, or it's not because surgeons don't do randomized control trials, but because these are particularly difficult challenges. And the RCT approach may not always work, and we do have many interventions in standard surgical practice that have not been through RCTs, unlike in medicine. But it's the best of what we currently have. And that's why it's really important to interpret results of RCTs, even the negative RCTs, with caution and pay attention to good quality observational trials. I think that concludes my talk. Thank you very much.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.